Hi, this presentation will introduce some information from the literature about treadmill training for infants with Down syndrome. Down syndrome, or DS, occurs in 13.65 out of every 10,000 live births. DS is a genetic disorder which causes mental and physical developmental delays. Severity of DS symptoms varies from person to person. However, infants with DS often experience a significant delay in walking onset and a slow or abnormal development in their gait patterns as a result of ligamentous laxity and low muscle tone. They might start independent walking a year or more later than infants with typical development, but infants can actively explore the environment and learn more about the world when they become able to walk independently. Therefore, infants with DS need early physical therapy intervention to help them develop walking milestones. What is a possible intervention that can be used for developing walking in infants with DS? Recent studies have demonstrated that treadmill training is one of the interventions that can facilitate the onset of independent walking. And consequently, this intervention might improve the development of joint kinematic patterns in this population. So, the physical therapists need to understand how to conduct this intervention appropriately. I have searched the literature to answer the following question. How can the best developmental outcomes be reached using a treadmill intervention in infants with DS? Two studies have compared the outcomes of two different intensities. The first study investigated the short-term effect in a randomized trial, and the design of this study was a pre-test, post-test control group design. 30 infants with DS were randomly assigned to a higher intensity individualized treadmill training group or a lower intensity generalized treadmill training group. The mean corrected age was 9.65 and 10.40 months for both groups respectively. Each family received an infant-sized treadmill and then received training on using that treadmill. Two members from the research staff directed the follow-up sessions once every 2 weeks. During these follow-up sessions, researchers were able to follow the family's compliance with the protocols and respond to their inquiries and videotape the stepping performance on a treadmill for 1 minute 5 times. The LG group, as you see in this table, received 8-minute daily training for 5 days a week. The build speed was fixed for this group at 0.15 meter per second. In contrast, in the HI group, the evaluators started to apply ankle weights and increase the previous build speed and duration when infants became able to achieve 10 steps each minute on a treadmill. The treatment was ended once the infant became able to take 3 independent steps on the ground. Also, parents were instructed to record the information about their daily application in logs. And you can see in these tables that some differences existed between the intended and the actual protocols. And this means that parents didn't follow exactly the intended protocol. Authors used the video-recorded 5 one-minute trials to assess stepping performance over time. The stepping performance was recorded every 2 weeks, and a total of 5 points was chosen. They also used the motor subscale of the Bailey scale of infant development that included 8 milestones to assess the onsets of each milestone by reporting infant's age at the time of acquisition. They used the mixed model, 2 groups, multiply 5 times analysis of variance, or ANOVA, to assess the stepping performance. Although they found significant interaction between groups and times, they didn't report using any post-hoc test, and this can be considered as a threat to the statistical validity of the study. However, they concluded that infants in the HI group had a significant increase in their stepping over the training period. They also found that significant statistical differences between the groups existed in two milestones, as you see below in the table, in moving forward using pre-walking methods and pulling themselves independently to standing position in favor of the HI group. You see in the table that means and standard deviations were used as descriptive statistics, which are commonly used with parametric testing. The authors here used these descriptive statistics with the non-parametric testing, Mann-Whitney, and this can be considered also as a threat to the statistical validity of the study. Authors reported that the effect size of 0.5 would be considered as a meaningful treatment effect, and this would indicate that the average child in the HI group acquired a motor milestone 0.5 standard deviation earlier than the average child in the LG group. So you see in the effect size column that the meaningful differences existed for the HI group in 6 out of 8 milestones. The statistical power was also low for these tests, and this was influenced by the participants' dropout from the study. Authors also conducted the PCA, which is a principal component analysis that treats the 8 motor milestone as a unidimensional locomotor construct. And they found that the infants in the HI group acquired the locomotor construct significantly earlier than the infants in the LG group. For the internal validity of this study, threats were as following. Examiners were not blinded, allowing bias that may have affected outcomes. 6 participants dropped out of the study, but their data were excluded and not calculated using intention to treat approach, which is also a threat to statistical validity. The statistical significance might have existed because of the natural maturation of the infants, as they were growing up during the long time period of the study. It wasn't mentioned whether infants were receiving an extra physical therapy intervention during the time of the study, or if they were trained by their parents using walkers, for example. So any history of other training could affect the outcomes. The reliability and validity of using the 5 1-minute trials to assess the stepping frequency over time were not supported by any evidence in the study, which could create some errors that affected outcomes. Although the data were verified by the assessors in the bi-weekly follow-up, determining the exact onset of the milestones on the Bailey scale depended on parents' evaluation, which might have been inaccurate. Furthermore, 2 members have visited all infants, but it wasn't mentioned whether the same assessor conducted the observational tests, which might have affected the observed changes in the dependent variables. The strengths of the study were as following. Randomized assignment maximized the probability of equal distribution of extraneous variables across groups. The inclusion and exclusion criteria were specified to generate a tight control over extraneous variables and reduce variability that might affect the result. So to be included, infants had to achieve at least 6 steps in a given minute while they were supported. However, participants were excluded if they experienced seizure, had untreatable optical issues, or had any associated health problems that would interfere with participation in the study protocol. Testing was conducted in a familiar environment, which is a comfortable place for infants to respond normally to testing procedures. The Bailey Motor Scale is known to have high reliability. The reasons for the loss of participants were clearly reported, and these reasons were the non-adherence to the protocol at all, or emergence of medical conditions. And overall, the data collection procedures were clearly described, and that makes it easy to replicate the study. There were also some threats for the external validity of this study. Results can be generalized only to populations that have the same criteria as in the study, such as infants who produce 6 supported steps in a minute, which is produced at a specific age or time point in their life. Providing each family with a treadmill at home to strictly follow the protocol might not be possible in the most settings, which limits the ability to use the protocol. These trends were as following. Results can be generalized to both genders and different ethnic groups. The clear description of the protocols allows this program to be easily applicable for other populations. As a conclusion, 94% of the infants in the HI group and 71% of infants in the LG group walked before 2 years of age. The ability to walk independently at least 3 to 4 months earlier than would be usually in infants with DS is clinically important. However, the application of a treadmill training depends on the availability of the infant-sized treadmill. Actually, I didn't try this intervention before, but I don't think that such a training can be applied with the adult-sized treadmill, because I don't think that would be safe, and it will be hard to hold infants on this kind of a treadmill. The second study was an extension for the previous study. In this study, the authors examined the effect of both interventions on the development of joint kinematic patterns during the first year after walking onset in the same groups. So, intervention procedure was mentioned in the first study. However, only 13 infants in each group completed a 1-year gait follow-up. In a laboratory, the researchers used a 6-camera peak motion analysis system to measure magnitude and timing of peak joint angles in the lower extremities in regard to toe-off in a gait cycle. The authors compared the results between and within the groups at four different time periods. The results revealed that the average peak ankle plantar flexion over all visits occurred significantly earlier in the HI group than in the LG group. Also, the duration of the forward thigh swing after toe-off increased in the HI group. The timing and magnitude of peak joint angles, including all other movements in all joints of the lower extremities, improved significantly in both groups. So authors concluded that the HI protocol facilitated the development of the ankle joint kinematics as compared to the LG group. The strengths and threats to the internal and external validity are same as in the previous study. However, I would add some differences. In the threats for the internal validity, it wasn't mentioned whether the reflective markers were placed by the same assessors all times and for all children, and that might result in producing some errors in the outcomes. For the strengths, the data were collected in a laboratory which applied a controlled setting for all infants, and the motion analysis system is a manufactured device that is considered a reliable tool. For the external validity, for the threats, the insufficient sample size and the tight control over the variables limited the generalizability to a broader population. For this study and the previous one, the infants were recruited through parent support groups in Lower Michigan. So, if parents were volunteering, they would be more likely to have their personal goals to adhere training, which might not be the same for the other population who are not interested and actively participate in the training. The sample size wasn't enough to achieve the intended power in the study, as the participants' dropout exceeded the 10%. So, there is a probability of committing type 2 error in the insignificant between group differences in the kinematics of other joints, and this is a threat to the statistical validity. As a conclusion, use of the HI protocol revealed a positive long-term effect as producing the peak plantar flexion and or before the toe-off can facilitate the mechanical transfer to initiate the swing phase without dragging foot on the ground. So this would generate a more rapid and coordinated gait pattern while participating in different activities in the daily living. The last study was a randomized controlled trial conducted to determine whether incorporating the early use of orthoses into treadmill training would improve motor skill development in infants with DS. The outcomes were compared between groups and over a period of time from when the infants were able to raise themselves to standing position until 1 month after their walking onset. 17 infants were randomly assigned to receive treadmill training or supramalleolar orthosis (SMOS) in addition to the treadmill training. Here is some information about the treadmill protocol for both groups. And the infants in the experimental group were SMOS during the whole duration of the study. However, infants in the control group just started wearing SMOS 2 to 3 weeks before the final visit after starting independent walking. The motor skill development was assessed every month using the gross motor function measure. There was no significant difference between groups in time to walking onset. Both groups improved total GMFM score significantly over time. At 1 month following walking onset, the score of standing, walking, running, and jumping were significantly higher in the control group. The internal validity might have been threatened as a result of rater bias due to the lack of the assessor blinding to group assignment. Subject attrition, maturation, history of other training outside the study protocol, testing in a laboratory just after 1 month of walking, which was unfamiliar environment to infants. The strengths included randomization, strict control over inclusion and exclusion criteria. For example, the study was limited only to infants who were able to pull themselves to standing position but not to cruise. The infants who have other developmental disorders and treated optical or auditory problems or previous orthotic use were excluded. The reasons for dropping out of the study were reported. The same researcher assessed all infants every month. The test, retest, and interpreter reliability were high when GMFM was used in children with DS. Some factors limited the generalizability of the study, such as a small sample size, strict inclusion criteria. Also, following a protocol depends on providing each family with a treadmill at home, and it can't be generalized to infants who need other type of orthoses. The results, however, can be generalized to infants with trisomy 21 who are able to stand independently but not to cruise and don't have any other health problems. The clear description of protocols allows the intervention to be easily applicable. To summarize, there was a large effect size in favor of the control group in the GMFM total score, standing score, and walking, running, and jumping score. And actually, the average infant in the group that received only treadmill training had a total score that was 1.55 standard deviations higher than that of the average infant in the experimental group. So the authors concluded that using SMOS as an early intervention during walking training probably restricted walking development. This study provided evidence that physical therapists may postpone using orthoses until the infants are able to walk independently after achieving the goal of a treadmill training. These studies provided initial guidance for therapists to use the treadmill training effectively with infants with DS. Further research that investigates the same interventions in a large sample size and calculates the data of participants who drop out using intention to treat approach (ITT) is required to improve the power of the study and overcome the common limitation across these studies. Furthermore, after searching the literature and finding that parents demonstrated poor adherence to the intended protocols, I was thinking that future research might investigate whether an intensive HI treadmill training program that includes clinical sessions in addition to the home sessions would facilitate the acquisition of motor skills in a shorter period of time. These are my references, and thank you for your listening.